Today we are going to discuss the swelling of the anterior abdominal wall or ventral abdominal wall. Before we discuss the pathology of the abdominal wall, we should know the basic anatomy of the anterior abdominal wall. As you know, then the center of the abdominal wall is a very fibrous, tough structure which is called linea alba, starts from the Z5 process to the pubic symphysis. Then there are two recti which meet in the midline, right rectus and left rectus abdominis. And these recti, they have got a tendinous intersections that shows the embryological development of mesodermal somites. These recti, they are covered interiorly by an anterior rectal sheath, and on the posterior surface it's called posterior rectal sheath. These sheaths are formed at the lateral border of the rectus abdominis, which is called as linea semilunaris. The anterior rectal sheath is formed by the fusion of the epinosis of the external oblique and the anterior lamina of the internal oblique muscle, which starts at the lateral border of the rectus and become continuous forward and ultimately joined in the midline by the anterior rectal sheath on the opposite side. The posterior rectal sheath is formed by the posterior lamina or layer of the internal oblique and the fascia transversalis by epinosis of the transverse abdominis muscle. And these two sheaths, they cover the recti both interiorly and the posteriorly, and linea alba is formed by the fusion of the epinosis of both the interior and the posterior abdominal wall as a thick fibrous band extending from Z5 process to the pubic symphysis. It is very broad and tough in the supraumbilical region, and it is a bit thin and in the midline below the level of umbilicus to the pubic symphysis. Anterolateral abdominal wall consists of three muscles: external oblique muscle, internal oblique, and transverse abdominis. The posterior rectal sheath is absent below the level of the umbilicus, midway between the umbilicus and pubic symphysis. Here there is the posterior rectal sheath, the posterior lamina of the internal oblique, and the transverse, they passes in front of the rectus abdominis and inserted there. The posterior rectal sheath is absent in the lower half of the infraumbilical area, and as the external oblique and the internal oblique and the transverse, which makes the posterior rectal sheath, they move in front of the rectus abdominis and creates a line which is called as semicircular fold or of Douglas. So there are two things. One is a lateral border of rectus abdominis, which is called as linea semilunaris, and the other arched or semilunar or semicircular fold, which is present in the lower half or below the umbilicus, where the posterior rectal sheath is absent and the posterior rectal sheath passes in front of the rectus abdominis. So that is why the posterior rectal sheath is absent in the infraumbilical area, and that is why the incidence of the incisional hernia is more in lower right paramedian scene. The umbilicus is central. And it is at the level of midway between the Z-fat process and pubic symphysis. The umbilicus changes position upwards as a result of the pelvic tumors, and the umbilicus moves down when there is a peritoneal fluid, free peritoneal fluid in the peritoneal cavity, like ascites. The abdominal wall has been divided in 9 quadrants by an imaginary line falling from mid-clavicle line to the mid-inguinal ligament, and similarly the other horizontal vertical lines falling from mid-clavicular down to the inguinal ligament. There are 2 horizontal planes. One is the subcostal plane and other one is the transtubercle plane. Subcostal plane passes below the costal margin at the level of the 10th costal cartilage, and the other horizontal plane is transtubercle plane, that is highest points of the iliac crest. You draw a line horizontally. So these 2 vertical lines and 2 horizontal lines on the abdominal wall divide into the 9 quadrants. That is epigastrium, right and left hypochondrium. Then the right hypochondrium, left hypochondrium, epigastrium, right lumbar region, umbilical region, left lumbar region, right and left iliac fossa, and the central one is the hypogastrium. But these anatomical landmarks are very important because the various viscera lying in the peritoneal cavity, they are present in relationship of these quadrants of the abdominal wall. The commonest swelling which appears on the abdominal wall or ventral abdominal wall in the area of the groin. Groin is the area which is above the level of the inguinal ligament. The commonest swelling in the area of the groins is hernia unless otherwise ruled out. The diagnosis of a groin swelling is based on one important test, physical sign, that is cuff impulse. Cuff impulse is when you cuff it, there will be increase in the intra-abdominal pressure, and any swelling which contains the intra-abdominal content, there will be momentarily increase in the bulge on cuffing. This is called cuff impulse positive. That is very important. Cuff, and you inspect it or you can palpate the swelling, and you will find there is a momentarily increase in the bulge because of transmission of the pressure will show a momentarily increase in the bulge of the swelling. This is called cuff impulse. It's a very important physical sign of any swelling on the anterior or ventral abdominal wall. The commonest hernia on the anterior abdominal wall are the groin hernias. The swelling which appear in the area of the groins, groin hernias, they constitute a 75%. 10% they are the incisional hernia or called ventral hernia, and the rest is constitute the other types of the hernia. In the groin hernia, First, you know the definition of a hernia. Hernia may be defined as a protrusion of a viscus or a part of viscus through the normal or abnormal openings is called hernia. Protrusion of a viscus or a part of the viscus through the normal or abnormal openings. Or other way you can say it is the protrusion of the intra-abdominal tissue through the facial defect is called hernia. Hernia is basically a defect through which the intra-abdominal contents come out. The commonest groin hernia are the inguinal hernia and little percentage of the groin hernia is the femoral hernia, which is not so common. The inguinal hernia are more common, and the inguinal hernia, there are two types. One is the direct and other is the indirect inguinal hernia. Before we discuss the inguinal hernias or groin hernias, we should know the anatomy of the inguinal canal. The inguinal canal is an oblique passage, roughly about 4 cm above the inguinal ligament. This inguinal canal has got two rings. One is the deep inguinal ring, the other is the superficial inguinal ring. The deep ring is the opening in the fascia transversalis, which is equidistant between the anterior spear-like spine or the tubercle. Or the other way you can say deep inguinal ring is the opening in the fascia transversalis ½ inch above the mid-inguinal point. That is the opening in the fascia transversalis. That is deep ring. The other ring is called superficial inguinal ring, which lies above and medial to the pubral tubercle, and it is an opening in the aponeurosis of the external oblique. If you look at the boundaries of the inguinal canal, the inguinal canal inferior wall is formed by the inguinal ligament. The superior wall is formed by the conjoint tendon, formed by the aponeurosis of the internal oblique and the transverse, and these conjoint tendon medially is attached to the pubic crest. The posteriorly it is formed by the fascia transversalis, and anteriorly is the external oblique aponeurosis. These are the boundaries of the inguinal canal. Posteriorly fascia transversalis, superiorly conjoint tendon, inferiorly the inguinal ligament or Pupat's ligament, and the anteriorly is the external oblique aponeurosis. The inguinal canal contains a very important structure in the male is called spermatic cord. If If you look at the supramotor cord, it is encircled by a muscular fiber which is called cremastic muscle that wrap the supramotor cord. This cremastic muscle arises from the internal oblique muscle. The important contents of the supramotor cord is vas deferens, vessels, which includes the testicular artery, artery to vas deferens, veins pimpiniform plexus, lymphatics, genital branch or genitofemoral nerve, and the most important structure, which I am telling you at the last, is the most important. That is causing the pathology in the area of the groin is process vaginalis. Process vaginalis is the peritoneal extension which is attached and to the upper pole of the testes, and the gubernaculum testis is a fibrous band which is attached to the caudal pole, drags the testis down into the base of the scrotum. While the testis is descending down, there is also a peritoneal extension which is attached to the superior pole of the testis. This peritoneal extension, the distal part of it, it covers the anterior and the anterolateral surfaces of the testes. That layer is called as the tunica vaginalis. Rest part of the process vaginalis gets obliterated. So the process vaginalis is a very important constituent of the spermatic cord, and that is a cause of pathology of indirect inguinal hernia in most of the cases. So it is a patent process vaginalis which has the connection inside the abdominal cavity, and if this process vaginalis or part of it remains patent, any raise into abdominal pressure, when the rings become deep inguinal rings, dilated one, the intra-abdominal contents can slide into this peritoneal extension, which is called process vaginalis, that makes the form of the sac. So that is the important structure in the spermatic cord is the process vaginalis, the distal part of it converted into as surrounding the testes anteriorly, laterally and posterolaterally is called tunica vaginalis. And as you know, the tunica vaginalis is attached anteriorly, laterally and posterolaterally, leaving behind a part of the testis bare posteriorly. And this tunica vaginalis, when the fluids collects into it, that is called hydrocele. Serous collection or collection of the fluid in the tunica vaginalis, which present as a hydrocele in the scrotum, and that is called also the vaginal hydrocele. So the majority of the hernias, they are indirect because of the patent process vaginalis. The other, that what are the structures which exit out of the superficial inguinal ring? One is the spermatic cord, and second is the ilioinguinal nerve. So there are three nerves which you remember when you are doing the operation of the inguinal hernia. One is the ilioinguinal nerve. It is essentially derived from L1, supplies the ipsilateral side of the penis, scrotum, and the medial side of thigh. Ilioinguinal nerve is also a motor nerve to the cremaster muscle. So if the nerve is cut, the cremasteric reflex absent. The other nerve is the iliohypogastric nerve, which appears on the superior wall of the inguinal canal, a centimeter or two above the conjoint tendon, underneath the external oblique, and this supplies the conjoint muscle. The third nerve is the genitofemoral nerve, which is the content of the supraumbilical cord, and the genital branch is motor to the cremasteric muscle and sensitive to the area of the ipsilateral side of the scrotum, and the femoral nerve supplies the lateral part of the thigh below the inguinal ligament. These two nerves, ilioinguinal nerve, can be damaged during the hernia repair, inguinal hernia repair, and the most common nerve which is vulnerable to be damaged is the ilioinguinal nerve that leads to numbness in the ipsilateral side of the penis, scrotum, and the medial side of thigh. This inguinal nerve, ilioinguinal nerve, and the supraumbilical cord both emerge out from the superficial inguinal ring, and the cord then descend down and become the part of the epididymis, because the cord jumping from plexus and the vas deferens goes from the epididymis into the ampulla of vas or seminal vesicles, and ultimately ejaculative ducts which open into the urethra. In the female, the supraumbilical cord is presented by the round ligament of uterus. So this is, and if you look at the posterior wall of the inguinal canal, which is formed by the fascia transversalis, behind the fascia transversalis, in the middle of the inguinal canal on the posterior wall, there are inferior epigastric vessels. These inferior epigastric vessels, the vein and the inferior epigastric artery, which is the branch of the external iliac artery. Indirect inguinal hernia is the hernia which comes out through the deep inguinal ring as the ring gets stretched. And the direct inguinal hernia comes out through the posterior wall of the inguinal canal. Here it is very important, the inferior epigastric vessels makes the lateral boundary of the Hazelbach triangle. Hazelbach triangle is the part of the posterior wall of the inguinal canal which is medial to the inferior epigastric vessel. Hazelbach triangle is basically formed below by the inguinal ligament, laterally by the medial border of the inferior epigastric vessel, and medially it is bounded by the lateral border of the rectus abdominis. So this is called Hazelbach triangle. Boundaries, again remember, inguinal ligament below, inferior epigastric vessels laterally, and the lateral border of the rectus abdominis medial. The inguinal hernia, indirect inguinal hernia, which usually occurs in the children, infants, or adults, sac comes out, hernia comes out through the deep inguinal ring into the inguinal canal. It may descend into the scrotum. The indirect inguinal hernia on the operation table, how you diagnose. If the neck of the hernial sac lies lateral to the inferior epigastric vessels, it is called indirect inguinal hernia. And if the hernia sac is coming directly from the posterior wall of the inguinal canal to the Hazel-Patch triangle, it is called direct hernia. So the hernia which is lateral to the inferior epigastric vessel in true sense is indirect inguinal hernia, and the hernia which lies medial to the inferior epigastric vessel, it is called direct inguinal hernia. So sometimes the hernia becomes so large, difficult to differentiate, it is a direct or indirect. So the true definition is on the operation table. Direct hernia is lateral to the inferior epigastric vessel, and the direct hernia is medial to the inferior epigastric vessels. If both the direct and indirect hernia is present, there is also direct hernia and also the indirect sac also there. This type of hernia, in between it is the inferior epigastric vessel. This is called pantaloon hernia. The commonest content of the hernia is the omentum, which is a mobile force. It is a very freely mobile in the peritoneal cavity, so the part of omentum may be trapped into the hernial sac. The second common thing is the small intestine. The part of the intestine or the segment of the wall of the intestine may be entrapped or prolapsed through the deep inguinal ring. So the commonest content is the omentum, which is called omentocele, and the second commonest content, a part of the intestine, is called enterocele. The shape of the indirect inguinal hernia is oblong or piriform shape, and if you inspect the direct inguinal hernia, it's just a circular round like a tennis ball, and which bulge out, which comes out directly through the posterior wall of the inguinal canal. Both the hernia lies in the inguinal canal. One is coming directly from the posterior wall of the inguinal canal, and other is coming through the deep ring into the inguinal canal. As I have told you, the diagnostic sign is the cuff impulse. Second important sign on physical examination of the swelling, if you can get above the swelling, it is hernia. If you can't get above the swelling, it means the swelling is rising on the wall. So, like this one, a swelling which is inguinal scrotal, to differentiate that this is a hernia or this is a hydrocele. If you can get above the swelling, it is a hydrocele, or the swelling which is rising either from the scrotum or the spermatic cord or the posterior wall of the abdominal wall. But if you can't get above the swelling, it means it's coming out through the abdominal cavity in the inguinal canal, and that is why this is labeled as hernia. So, can you get above the swelling or you can't get above the swelling? It's a very important physical sign to appreciate the swelling is a hernia or something else. It makes no difference the hernia is direct or indirect. All the hernias in the groin which are symptomatic must be repaired. Majority of the hernia, they are indirect. That is a result of patent process vaginalis, through which the evagination of the abdominal viscera occurs. There's few certain terminology you should know it. One is the hernia become irreducible or hernia is incarcerated. Remember, incarceration means irreducible. Don't confuse with the obstruction and strangulation. Hernia may be reducible or hernia may be irreducible. So method of reduction is some hernia they reduce spontaneously, some hernia swelling reduce manually, or some reduce by lying down position. Supine position, spontaneous or manual reduction. The hernia which is irreducible is called incarcerated hernia. The incarcerated hernia or irreducible hernia has the tendency to undergo obstruction. When I say obstruction, the loop or the part which is evaginated in the hernial sac is not reducible because of the narrow neck of the sac. So if the hernia become irreducible, there are chances of obstruction or strangulation. The difference between the strangulation or obstruction is, you should remember, any hernia which has had history of recent irreducibility. The patient was all right, all of a sudden this swelling, he cough out and it doesn't go back and it's become irreducible. And if the patient complained of pain and on touch there is tenderness, the diagnosis is strangulation. Even though it doesn't, or it is very difficult to differentiate between the strangulated hernia or the obstructed hernia. Every strangulated hernia is obstructed hernia, is incarcerated, irreducible, obstructed hernia. So every strangulated hernia is obstructed hernia. But the additional signs is there is a jeopardization or compromisation of the blood supply of the contained viscous in the sac. When the blood supply is compromised, initially first there is a irreducibility, then there is the as a result of the compression, there is a venous obstruction first because the veins can easily be obstructed. They are thin walled, so then there is a fluid come out from there, from the veins, and the pressure build up, and then there is a also compromisation of the arterial supply. So once the hernia is strangulated, when there is jeopardization of the blood supply of its contents, it is called strangulation. Every obstructed hernia which is recent onset is strangulated unless until otherwise ruled out. When the patient has got a recent history of strangulation or irreducibility, you treat him as a strangulated hernia, as an emergency. Patient come to the hospital, and I think you should operate as early as possible from the time of onset of irreducibility. Early you will operate, there are higher chances that you can save the intestine if it is there or omentum. If there is a delay more than 4 to 6 hours and there is a severity of strangulation or the constriction at the deep inguinal ring, or very rarely at the superficial inguinal ring if there is a complete hernia, then the ultimate strangulation leads to gangrene. And this gangrene needs resection, no matter it is a part of the omentum, no matter it is the part of the intestine. So every obstructed hernia should be treated as a strangulated hernia, and you operate as early as possible from the time of onset of pain or irreducibility. This is about the intracranial hernia. It should be repaired because there is always fear of incarceration, obstruction, and strangulation. Obstruction and strangulation is very uncommon, rare in inguinal hernia because there is a diffuse bulge, there is a diffuse weakness of the posterior wall of the inguinal canal until there should be a discrete defect in the posterior wall which leads to a funicular type of the inguinal hernia, then there are chances of strangulation. As the weakness is diffuse, the bulge is diffuse, so that is why the chances of irreducibility or incarceration or obstruction or strangulation is rare because the hernia sac is coming, the neck of the sac is broad because a diffuse bulge or weakness of the posterior wall of the inguinal canal. Rarely you have a discrete defect in the Hazelbach triangle on its posterior wall where the chances of irreducibility or obstruction is there. By and large, they do not descend into the scrotum, they are usually incomplete. The intracranial hernia can stay on the inguinal canal and it can emerge out and descend down into the scrotum, which is called as the complete intracranial hernia. How you able to differentiate between the direct and indirect inguinal hernia? The first thing is that you should know what is the mid-inguinal point. If you look at the inguinal ligament, it attached between the anterior spear-like spine to the pubic tubercle. This is called inguinal ligament or it's called Pupat's ligament. The deeper fibers of the inguinal ligament at the medial end, they splay out and attach to the pubis, and that part of the inguinal ligament is called as the lacunar ligament. And there is other ligament which passes behind the femoral vessel against the pubic bone, spear ramus of pubic bone, is called pectineal ligament or is also known as the Cooper ligaments. So you have got inguinal ligament, medially is the deeper fiber which is attached to the spear ramus pubis as a crescent edge which form the medial boundary of the femoral ring, which is called lacunar ligament. And deep to the femoral vessels against the spear ramus of the pubis along the iliopectineal line is called pectineal ligament or Cooper's ligament. So the Cooper ligament and pectineal ligament is posteriorly placed. Inguinal ligament is interiorly placed. Or you can say the ligament which is over the surface of the spear ramus of pubic bone passing behind the femoral vessel. This ligament is called Cooper's ligament. So these ligaments you should know it because if frequently we use these ligaments for the repair of the inguinal hernias or femoral hernias. Actually, the inguinal ligament is attached between the anterior spear-like spine and the pubic tubercle. Mid-inguinal point is a point which is at equidistance between the anterior spear-like spine and the pubic symphysis on the inguinal ligament. Mid-inguinal point is the point on the inguinal ligament, equidistance between the anterior spear-like spine and the pubic symphysis. This is called mid-inguinal point. You can locate the anterior spear-like spine by palpating the the groin coming from below upward, then the first bony prominence will be the anterior sphenoid spine. If you palpate the groin from medial to lateral, the first bony prominence you see is anterior sphenoid spine, and similarly, if you draw a line from the umbilicus, there is a midline from umbilicus which falls on the pubic symphysis. So that is the middle end. So you can have two landmarks. One is the point on the pubic symphysis, and that is a vertical line you can see dropping from umbilicus to the pubic symphysis, and that shows the center of pubic symphysis. And the other one is the anterior sphenoid spine. If you palpate the groin from medially to the lateral side, the first bony prominence is the anterior spine. So if you draw a line between the anterior sphenoid spine and pubic symphysis, the middle of that line will lies the deep inguinal ring, because the attachment of the inguinal ligament is convex downwards because of the attachment of the iliopubic tract or deep fascia. So as the mid-inguinal point is the point on the inguinal ligament, which is equidistant between the anterior sphenoid spine and pubic symphysis, and the deep ring lies ½ inch above the mid-inguinal point in the fascia transversalis. So if the line is straight and the midpoint of line is already ½ inch above the mid-inguinal point, because the inguinal ligament is convex downwards as a result of attachment of the fascia lata. So that is how you locate the deep inguinal ring. The second point is the middle inguinal point. Middle inguinal point is a point which is equidistant between the anterior sphenoid spine and the pubic tubercle. Middle inguinal point is the midpoint of the inguinal ligament from its origin to insertion, the pubic tubercle. Mid-inguinal point is the point at equidistance between the anterior sphenoid spine and pubic symphysis on the inguinal ligament. And the inguinal ligament is convex downwards, so the deep inguinal ring, if you draw a line with foot or tape, the straight line, the midpoint of that line is already ½ inch above the mid-inguinal point, and that is the place where, and that is the landmark or surface anatomy of the deep inguinal ring. I am pressing so hard about this one because the examiner, they asked in the examination, what is the attachment of the few parts on inguinal ligament, what is the mid-inguinal point, what is the middle inguinal point, and where is the deep inguinal ring. You reduce the hernia manually or ask the patient to reduce himself, and then you draw a line between the anterior sphenoid spine and pubic symphysis and half, and the midpoint of that, and you press the thumb, place a thumb there and ask the patient to cough. If the hernia does not appear, this is called cough impulse is positive, and if the hernia appears, it means it is coming through the directly from the posterior wall of the inguinal canal, so that is why they call direct inguinal hernia. Cough impulse positive means no hernia comes out. It means the ring occlusion test is positive, and the hernia, when you leave the thumb and hernia comes out, it means it is coming through the deep inguinal ring, and that is why it's called cough impulse or is positive, and the ring occlusion test is positive. And the ring occlusion test is positive in indirect inguinal hernia, and it is negative in case of a direct inguinal hernia. But these are just the tests you do it, but actually it doesn't matter the hernia is direct or indirect. All these symptomatic hernia should be repaired unless there is some reason not to do it, because they can be done under general anesthesia, spinal anesthesia, and even under local anesthesia. So, but their true definition to differentiate between the direct and indirect inguinal hernia is if the neck of the sac lies lateral, is called indirect inguinal hernia. If the neck of the sac lies medial, it is called direct inguinal hernia. And the complication of hernia is one, If they are symptomatic, pain, big swelling, or there are chances of incarceration, obstruction, and strangulation. So they must be prepared if they are symptomatic. What sort of repair you will do it? The, the treatment of hernia, the hernia is a defect. The treatment, the defect is repair. In inguinal hernias, you make the suprainguinal incision parallel to the inguinal ligament in its medial half, incise the external oblique aponeurosis and open the superficial inguinal ring. The important structure which can be damaged when you are opening the aponeurosis, the external oblique muscle to the superficial inguinal ring, there is a nerve which is anterior to the spermatic cord, is the ilioinguinal nerve. So one should take to avoid the injury to the ilioinguinal nerve, and if it is cut, it can only cause numbness on the medial side of the thigh or ipsilateral sensory loss on the scrotum. The cord, divide the gymnastic muscle which is wrapping the cord, then you expose the cord, and the sac usually lie anteromedially. The peritoneal sac, dissect it out right up to the deep inguinal ring, open the sac, reduce the contents, and high ligation of the sac at the level of the deep inguinal ring. It's called herniotomy. If the sac is big, leave the distal sac and you divide the sac and dissect it proximally to the deep inguinal ring and transfix it as high as possible at the level of deep inguinal ring, which is called herniotomy. After doing herniatomy is a good enough operation for infants, children, and adolescent age, because the inguinal canal in adolescent age or in children is all right. It is only the patent process vaginalis. You do a good high herniatomy, and if the ring is slightly dilated, you can put a 1 or 2 stitch. That is called plication of deep inguinal ring is enough. There is no need to repair the posterior wall of the inguinal canal. In children, in infants, or in adolescent age, but when the patient has fully adult in 30s and 40s, it is always added the repair of the inguinal canal. The herniatomy is the isolation of the sac and high ligation of the sac. In children and infants, herniatomy is enough. And if the ring is dilated deep, you can put a couple of 1 stitch around the deep ring to snugly fit the cord against that ring. In adults or elderly people or middle age, you always do repair. There are 2 types of repair. One is the native tissue repair or autologous tissue repair, that you repair with their own tissues. The second repair you can do with the mesh. Mesh, there are 2 types: unbiological, non-biological, and biological mesh. The unbiological mesh are the Porcelain mesh, is made of polypropylene, or the other common mesh is the nylon. So there are 2 meshes, which these are synthetic mesh on the another mesh which is called Gore-Tex, which that mesh is used for vascular graft, is a PTA, polytetrafluoroethylene. Nylon and the Porcelain mesh, they are used for the repair of the hernia. They are known or unbiological. These are the mesh which are available in the markets, and they are made of monofilaments, polyethylene mesh or nylon mesh. When you have done the herniatomy, what sort of repair you do it? If the hernia is not strangulated, there is no fear of contamination or sepsis. Today, current practice is you do the herniatomy, plicate the fascia transversalis, and they put a mesh between the conjoint tendon and the curved margin of the inguinal ligament. Apply a few stitches on either side, and that will strengthen the posterior wall of the inguinal canal. This is known as mesh hernioplasty. This mesh hernioplasty, the incidence of recurrence is low, 2% on large series. And this repair is tensionless repair. The tension of the repair is very low. So any repair which is without tension has a lesser chances of recurrence. So mesh hernioplasty is also known as the Lichtenstein repair. You do the herniatomy, you place the mesh between the conjoint tendon and the curved margin of the inguinal ligament on the posterior wall. Recurrence is less, tension of the repair, low tension repair, or rather you say no tension repair, that has got a very lesser chances of recurrence in the hands of the same surgeon who does the native or autologous tissue repair. That is the Lichtenstein repair is the current practice of repair today. Lichtenstein repair, mesh hernioplasty after doing the herniatomy and plication of fascia transversalis with a monofilament 3,0-proline, which further strengthens the posterior wall of the inguinal canal. You plicate it with interpretive sutures and then replace the mesh over it. Recurrence usually in experts and less than 1%. The second repair is if the strangulated hernia and the gut is gangrenous, you resect the gut and put it back. There is a cross contamination of the wound, and there are higher chances of sepsis or infection of the wound. Under these situations, it is better to repair with the native tissues. There are multiple autologous tissue repair. The oldest repair is the Besseny's repair. What you do it, you take the conjoint tendon with a strip of the fascia transversalis taken within the bite, which means the upper flap is conjoint tendon and the fascia transversalis, and then you stitch to the curved margin of the inguinal ligament with the interpretive sutures, which is called as the Besseny repair. This old repair in 1880, they just stitched the conjoint tendon containing the upper, containing the fascia transversalis upper flap, and they stitch to the curved margin of the inguinal ligament. This is called Besseny's repair. You have to make a tenor slide on the interior rectal sheath so that the suture line should not be under tension. This is called tenor slide. That you make a reverse L-shaped incision on the interior rectal sheath for relaxation of the conjoint tendon, so the repair should be under less tension. This is Besseny's repair done 50, 70, 80 years we are doing the same, and these are good results because there is a misnomer about the Western repair that they stitch the conjoint tendon, the curve margin of inguinal ligament. Actually, this is not the Western repair. In the Western repair, in the bite of the conjoint tendon, you also take the part of the fascia transversalis, and then you stitch it with the curve margin of the inguinal ligament. So fascia transversalis is always included in the upper flap when you stitch the conjoint tendon to the curve margin of the inguinal ligament. So this Western repairs with the Tanner slide is the very popular operation in 19th century. And in the middle of 19th century and later on, there are other autologous or native tissue repair is that if you bring the cord under the external oblique epinosis is called Western repair, and if you bring the cord in the subcutaneous tissue and you stitch the external oblique epinosis behind it, it is called Halsted repair. What is also called Halsted repair. The technique is same as the Western repair, but in Western you place the cord in its normal position, you stitch the epinosis external oblique muscle over it, but if you bring the cord subcutaneously and the epinosis of the external oblique stitch behind the cord, this is called Halsted repair. It is also known as blood goods repair. The other autologous or native tissue repair which is done when there is a fear of infection of the mesh, the condition they are not conducive, that is sterilization is not good, you are working in district hospital or the hospital where the sterilization is not up to the mark and you have a fear, I think the better thing is that you should do the native tissue repair or autologous. Same thing, you repair with its own tissue of the patients. You don't use any foreign material. So the suture material which is used in the native tissue repair is Porolene, which is polypropylene, and that is a thread which should be used for the repair of the all hernias, no matter they are native autologous tissue repair or you can use this thread for the mesh hernioplasty, because the thread should be monofilament and non-absorbable. The commonest repair we do in hospital is the modified down repair. In this case, you don't use any mesh, you do herniatomy. You plicate the fascia transversalis, and with 0 or number 1 Porolene, you make a lattice network between the curve margin of the inguinal ligament and the conjoint tendon. And this lattice network is just like the wires between the two poles. That is, one is the conjoint tendon, other is the curve margin of inguinal ligament, and these wires or these Porolene thread which makes a lattice network between the conjoint tendon and the curve margin of inguinal ligament with non-absorbable suture material Porolene, 0 or sometimes 1, usually 0 is enough, and then you make a lattice network, एक बुनती सी डाल देते हैं between the curve margin of inguinal ligament and the conjoint tendon. और ये जो suturing जो हमने किया, जो हमने lattice network बनाया है, ये टाइट नहीं होना चाहिए, just pass on the stitches from one side to other side, and they should be loose. Actually, these thread will invite the stimulation for the fibroblast, and the fibroblast they will grow on these lattice network of which you have made between the conjoint tendon and inguinal ligament, and that provides the strength to the posterior wall of the inguinal canal. The advantage of the mesh is it strengthens the wall, but this also lattice network also strengthen the wall. The advantage is when you have got a gross infection and sepsis, so avoid to use the mesh because mesh can, as a foreign body, can act as a nidus for infection and the discharging sinuses and the wound gets infected if there is already gross contamination or you suspect the sterilization is not up to the mark. So that is why the autologous or native tissue repair is more. Nowadays we do is this is called modified down repair. Modified down application of the transverse cellus after herniatomy, and then we make a network or lattice network of the poroline between the curved margin of wing 1 ligament and the conjoint tendon. This repairs, majority of the surgeons, they are doing it. Is a very good and sound repair. In old days, they do the another repair which needs a lot of dissections, and that repair is not done nowadays because a lot of dissection is required and it cannot be done in a recurring one and hernia, and that is called as the application of both the fascia transversalis, conjoint tendon with curved margin going on in ligament, and the epinosis of the external oblique, also extensive dissection and 3 layers. That is called the very famous university in Canada, and this is called as the, but this repair is not applicable into the other thing. This is called shoulders repair. Dr. Shoulders. This is called shoulders repair. It's not done in a recurrent hernia. It's not possible to do it in case of obese people. Shoulder repair. Shoulders repair is very popular about 20-30 years back because it's autologous tissue technique, and you make a 3 layers. You divide the fascia transversalis and again suture it in 2 layers. You divide, and then you again repair the conjoint tendon, or you can stitch the conjoint tendon in 2 layers with the curved margin of the one ligament, and then you also double breast technique, repair of the external oblique epinosis. But a lot of dissection is required. I think the better option is, if you want to prevent the recurrence is there and the condition is conducive, mesh hernioplasty has stood the test of time, and that is called, which I told you, that is meshes of polyethylene or nylon. In retroinguinal hernia, the treatment is the same as indirect, that is either mesh hernioplasty or modified down repair or basin repair with tender slide. The one hernia is also another variety of hernia is called sliding hernia. You should remember, sliding hernia is a variety of intrainguinal hernia, in which the wall, the part of the wall of the sac is formed by the wall of the abdominal viscus, and on the right side is usually the cecum, on the left side the sigmoid colon, and sometimes the urinary bladder wall also slides in the sliding hernia. In sliding hernia is difficult to diagnose. You can only suspect when you find a large hernia with a broad neck, because sometimes the cecum on the left or sigmoid colon on the left and the cecum on the right side can slides, and the wall of the cecum or the colon form the posterior wall of the sac. If you don't recognize the sliding hernia, there are chances you can damage the intestine. You can open the sigmoid colon on the left side or cecum on the right side. It's very important, you must appreciate, because the sac wall is formed by the part of the wall of the intestine. So this is very important to recognize if it is there, and in that situation we push it back, the sac with inverting sutures on the peritoneum, that is called Bevan techniques, and then you repair after pushing the sac and the contents into the peritoneal cavity or abdominal cavity. You repair as such. You can, I think the best repair in this situation, as the defect is very large in the posterior wall of the inguinal canal, it is prefer to do the mesh hernioplasty. That is called lichen or Lichtenstein repair. That is the best option. You should always put a mesh if you have not resected the intestine or you have not damaged the intestine during your dissection of the hernial sac. Very important to know on the operation table, is the hernia is sliding or not. You can see the wall of the cecum or sigmoid colon, which is also prolapsed and making the wall of the posterior wall of the, making the part of the posterior wall of the sac. If this gut is strangulated, usually the sliding hernias, they are not strangulated, they are irreducible. Sometimes the hernia is too large, the whole sigmoid colon or the cecum, which has poor fixity to posterior abdominal wall, slide into the scrotum. Big, huge hernias is a difficult problem what to do. The answer is that you expose the hernial site, reduce the, break the adhesion in the scrotum, but this big sac, this big intestine cannot be put back through the inguinal approach. The answer is you make another incision, transabdominal incision, midline incision, and then you, within the peritoneal cavity, push and pull, both work together, and very gently you can withdraw the intestine from the groin, very slowly, gently, by light compression of the intestine and guide them through the deep ring, going slowly and back to the peritoneal cavity. So in that situation, never try to reduce the intestine, especially sigmoid colon or large or cecum, push it back from the groin. No, you can perforate the intestine. Better thing is that you should also have another incision is made on the abdominal wall, and through the abdominal cavity you can guide and withdraw the intestine by gentle push from the groin side. And after that, in this situation, you can repair with mesh hernioplasty on the groin side. So this is one approach for the repair of the inguinal hernias. The other hernia, which is rare but is, if it is more common in the females, if it occurs, that is a femoral hernia. Femoral hernia is the herniation of the interabdominal content through the femur ring into the femoral canal. As the femoral canal is a very small canal, and the boundaries above is inguinal ligament, posterior is the pectineal or the Cooper's ligament, medially is the free edge of the lacunar ligament, and laterally is the medial surface or medial side of the femoral vein. Majority of the femoral hernia comes into the groin below the level of inguinal ligament, bit more laterally placed through the femoral ring into the femoral canal. And this hernia is usually incarcerated, irreducible. And there are higher chances of obstruction and strangulation of the femoral hernia because the femoral ring is usually very tight. In front ligament, behind ligament, medially ligament, and only a soft boundary is the lateral boundary where the femoral vein is. So majority of the hernia, they are irreducible, difficult to differentiate. It is a femoral hernia or a enlarged lymph nodes in the femoral canal, lymph node of Kluge. If it is a lymph node, if it is tender, usually the femoral hernia, when it's obstructed, it becomes tender, difficult to differentiate. But anyhow, if the lymph node you suspect, you look for the any septic area in the lower extremity, the buttock, the groin, the inferior infra-abdominal wall, and also perineum on the lower part of the anal canal. So that septic focus can drain into this lymph node. So, but sometimes very difficult that you can take the help of the ultrasound. Femoral hernia is always below and lateral to the pubic tubercle, and the inguinal hernia is always above and medial to the pubic tubercle. Sometimes it is difficult to differentiate between the inguinal hernia and the femoral hernia when the sac comes out through the fossa vallis of the femoral triangle and then it goes upwards over the inguinal ligament. It's a retort shape. But the neck of the sac is always below and lateral to the pubic tubercle or the inguinal ligament. If there is distortion of the groin crease, it is a femoral hernia. Groin crease is below the level of the inguinal ligament. So that is another physical sign on inspection about the femoral hernia and the inguinal hernia. The treatment of the femoral hernia is operation. Ultrasound will guide to differentiate between the hernia and the lymph nodes. It must be appreciated before the operation. Approach is inguinal approach, and that is also called Cooper ligaments repair, because as the space is very tight and the sac is behind the inguinal ligament and in front of the pectineal ligament, this is called Cooper's ligament. So its reducibility is a big problem. Sometimes you have to divide the inguinal ligament to release the obstruction, and then the sac is reduced, and you can do through the inguinal approach. It's a safe one, and if it's not possible to reduce, you can make a counter incision in the groin, in the below the inguinal ligament, break that ligament and push it back through the femoral ring into the peritoneal cavity. Sometimes you divide the inguinal ligament, but the repair is same as the Cooper's ligament repair. Pectineal ligament is a Cooper ligament behind the femoral vessels, and you can stitch the conjoint tendon with the Cooper ligament. That is the treatment of the femoral hernia repair is called Cooper ligament repair. This Cooper ligament repair you can do even for the inguinal hernia also. You do herniotomy and then you stitch the conjoint tendon with the Cooper's ligament or the pectineal ligament. This is called Cooper ligament repair for the inguinal hernia, femoral hernia. You can do the modified down repair for the basin repair for the inguinal hernia or the mesh hernioplasty. Majority of these cases there is no need of mesh. Just a couple of stitches between the inguinal, the conjoint tendon, brought it down and stitch with the Cooper's ligament and make a relaxing tendon slide on the anterior rectal sheath to relax that conjoint tendon. And that repair, femoral hernia repair, is also known as a modified or Cooper ligament repair. This Cooper ligament repair you can do for the inguinal hernia and as well as for the femoral hernia. It is autologous native tissue repair, no need of any mesh. So I think this is a better option For the treatment of the femoral hernia, always approach through the groin or inguinal incision, produce the content, and stitch the conjoint tendon to the Cooper's ligament, or the pectineal ligament is the other name of that. Stitch it with a couple of stitches, and that can treatment of the femoral hernia. The complications of the inguinal hernia, there are two, remember. One is the hematoma. If you don't do it, need tiny dissection, not careful hemostasis, and in the morning you come and you find the swelling of the scrotum. That is a bad sign for surgeons. That is, he is a brutal. Hernia dissection should be very meticulous. If you are rough, the vessel bleed and they will collect the blood in the scrotum, in the tunica vaginalis. So one complication is the infection. Infection is 1%. Second thing is the hematoma, either in the scrotum, it's called hematocele, or in the groin. When you damage the inferior epigastric vessel, then a big hematoma can form in the groin. So hematoma in the scrotum, called hematocele, if you get a swelling immediately after the operation, some hour in the groin, it means you have damaged the inferior epigastric vessel, which produce hematoma. So it has to go into the theater and evacuate the hematoma, tie the inferior epigastric vessels. Number two is the infection that occur after 3-4 days, and this infection, when it's occurred, you open the wound and drain the fluids, blood or serum, or if there's a gross infection, keep the wound open and let it should be healed by secondary tension and give appropriate antibiotics. Unfortunately, if the infection occurs in a mesh hernioplasty, it may be very disastrous at times because it doesn't control with the antibiotics, and ultimately after a couple of months or 6 months you have to remove the mesh, and this time the defect will be much more larger than the previous defect. So hematocele, wound infection, and the third complication is the recurrence. Recurrence is in mesh hernioplasty less than 1%, and on average overhaul, mesh or without mesh overhaul, is recurrence rate is 2 to 4%. And when the recurrence occurs within 6 months to 2 years, it means is a faulty technique. The surgical technique is not correct. So it is entirely depends on the surgeon's experience and his expertise in that particular technique or type of the hernioplasty. So this poor surgical technique is one of the cause of recurrence, which occur within 6 months to 1 year or 2 years. It is not the other risk factor which can cause recurrence. It's basically poor surgical technique. One should revise technique and proper bites and dissection of tissue. Sometimes you miss the indirect sac, which you read later on as recurrence of inguinal hernia. So missing of the sac, indirect sac, or missing of the femoral hernia, which can subsequently present as a recurrence of the hernia in the groin after the repair. Either you miss the indirect sac or you miss the femoral hernia. That is one of the two factors which can cause recurrence after that. Missing of the indirect sac during repair, or you have missed the femoral hernia. But if the sac is not missed, then the chances of recurrence within 6 months or 2 years is the surgeon's fault. Poor surgical technique. The other approach to tackle the inguinal hernia is the laparoscopic. Laparoscopic is minimal invasive technique. The cost and the duration of the time is more, post-operative pain is less, and patient may go to job very quickly within a week. The laparoscopic or minimal invasive approach, there are two methods. One is TAP, transabdominal periperitoneal mesh repair. Even this laparoscopic technique, you have to place the mesh one. And the second is TAP, which is more difficult. That is a total extraperitoneal approach with the placement of mesh. If the recurrence occurs laparoscopically, you repair from the front, open technique. And if the recurrence occurs with open technique, then you repair second time by laparoscopically. It is better to operate on a healthy tissues rather than the previously scarred tissues. In old days, we have got only one approach, that is the approach from the front. No matter you have done the passing repair, if it recurs again, you can do a mesh them. So whenever the recurrence occurs, you always approach from the front. But nowadays, it's a thing, if recurrence occurs after a front approach or open method, you can repeat this procedure laparoscopically. And if there is a failure or laparoscopically, then you can repair this hernia from front. And the laparoscopy is also good for the bilateral hernia or the recurrent hernia which has occurred from the front approach. This technique requires masters. Initially, the graph for the learning graph is very long, especially for TAP, and the recurrence rate was very high. It should be only done by those people who regularly do laparoscopic repair of the hernia by either technique, TAP, total extraperitoneal approach, or TAP, transabdominal periperitoneal plane mesh. So that is about the inguinal hernias. Now another hernia is very common, is the umbilical hernia. There are two types, umbilical and paraumbilical hernia. And this umbilical hernia in adults is through the umbilical cicatrix, and the ring is narrow, neck is narrow. There are higher chances of obstruction, incarceration, or strangulation. The second is paraumbilical hernia. That also comes out through the defect in the linea alba, either above the umbilicus or below the umbilicus. So if the hernia comes out through the linea alba, defect in the linea alba above and below, it's called paraumbilical hernia. If the hernias have come out through the umbilical cicatrix, it's called umbilical hernia. The common risk factors for hernia is, one is the age, obesity, heavy lifter, poor collagen synthesis, defect in the synthesis of collagen tissue, raised intra-abdominal pressure, multiple pregnancies, pelvic tumors, ascites, cirrhosis, peritoneal dialysis, or patient who is on steroids, malnutrition. So these are the risk factors which raise the intra-abdominal pressure, and that leads to herniation through the defect. Treatment, the incidence of strangulation, incarceration is very high for paraumbilical hernias because usually they are irreducible. The defect in the linea alba does not yield to pressure. The chances of strangulation is high. They should be, if this is strangulated, open it up. It may be intestine, omentum, or part of transverse colon. Small gut, if it is gangrenous, resect it. It is viable, put it back. When in doubt, take it out. Omentum, gangrenous, resect that part. small gut gangrene, resect that part and do primary anastomosis. If you find transverse colon paraumbilical hernia, resect it and make a colostomy. No primary anastomosis should be done in a strangulated paraumbilical or umbilical hernia in a large gut. Never do it. It will daze and you will get a fecal peritonitis. Repair is two, either you do Mayo's repair, you double press technique of for the anterior rectal sheath, overlap, double press technique, use monofilament, nylon or Porolene. If the defect of the paraumbilical hernia is large, you can use the mesh, only mesh made of Porolene, and you can stitch on the anterior rectal sheath all around the repair. This is called only graft, is made of mesh. Nowadays it's available in the here's very few places, but in United States I think they have got a biological graft. If there is a gross contamination, infection, sepsis, gut resection done, and the repair you don't want to do the native tissue repair because they are weak repair as compared to the mesh hernioplasty. So they use the mesh which is called as the biological mesh. It's made of human or animal. That biological mesh can prevent the infection. But the non-biological or unbiological mesh, they are higher risk of infections. So biological mesh are being used in the repair of the hernia when there is a cross contamination, infection, strangulation of the gut and gangrenous. So you don't want to use mesh. If you want to use mesh, then it should be a organic biological mesh. Bigger the size of the hernia, higher the chances of recurrence. Bigger hernia should be treated with mesh hernioplasty, no matter paraumbilical or the inguinal hernias. Umbilical hernia in the children should not be repaired until at the age of 5. Chances of incarceration, obstruction and strangulation is less in children, but the chances of strangulation, obstruction are more in adults umbilical hernias. You wait in the children for 5 years. Majority of the cases the umbilical ring gets obliterated within 5 years, and if the hernia still persists after the age of 5 years, you can repair it. But one thing you should remember, in children umbilical hernia doesn't undergo strangulation or obstruction as versus with the adults, where the umbilical hernia has got a higher chance of strangulation and obstruction because the ring is narrow, neck of the sac is narrow, and there may be chances of auto-compression which can lead to jeopardization of the blood supply of the contained viscous. Sometimes they ask in examination what is the layers of the hernial mass. It contains the skin, subcutaneous tissue, the sac, and then comes the content, maybe intestine or maybe omentum. Sometimes the other types of hernia they ask in the groin hernia is what is called Richter hernia. The Richter hernia is dangerous because knuckle of the intestine or this part of the wall of the intestine is entrapped in the defect, which can result in strangulation and gangrene. This Richter hernia, which can present as a strangulated hernia, but at the time of operation you want to prepare for the patient is this hernia reduce. So it means it's a dangerous, and if knuckle of the intestine is gangrenous, it's lying the peritoneal cavity, which is likely to perforate and cause peritonitis. So in these situations, one should auscultate the one should palpate the abdomen if there are any signs of peritonitis, or get a DLC if the total leukocyte count is high. And on the operation table, when you open the groin and you find there is a dark brown or blood stained fluid in the sac, that shows the sign that the part which was entrapped before, which has reduced spontaneously, is a gangrenous. So you just repair the hernia and then you open the tummy and search for the gangrenous loop of the gut, which a knuckle of the intestine may be gangrenous. So Richter's hernia is bad because it is one, it It's usually strangulated hernia. The knuckle of the intestine is trapped into the deep inguinal ring. And second thing, sometimes spontaneously it reduce and leave the focus of gangrene inside the peritoneal cavity. For that reason, one should be very careful pre-operatively, get the blood count for TLC and palpate the abdomen for peritonitis, and on the operation table very clearly look at the hernial sac, open it up, and if you find a dark brown blood stained fluid, that shows a sign the patient has got a gangrene of the part of the content or whatever the content which has come out. It has reduced spontaneously, and you can leave the focus behind in the peritoneal cavity. So you can lose the patient if you are not careful by doing the thing. Look at the sac, blood count, and the any signs of peritonitis. You should decide before or on the operation table, but don't sit on it. If you think that there is signs of peritonitis, you have to open the tummy and dissect that part. If you think on the operation table you find the sac is there, is empty but no content, but the fluid is dark stained and blood stained, the answer is you have to explore the abdomen, look for the gangrene patch. Or third one is the blood leukocytosis, that shows signs of severe inflammation or necrosis. This type of hernia is called Richter's hernia. It is a variety of intraduodenal hernia. Knuckle of the intestine is entrapped into the deep inguinal ring. The other hernia, which is called as the Litter's hernia. In Litter's hernia, you find the appendix is there, and if the appendix is okay, don't remove it, put it back, and you repair as such. Maybe the appendix is gangrenous and perforated. If you can take the appendectomy down and add to the same wound, is okay, but sometimes it is not possible. You repair the hernia and you do proper appendectomy by open method, whatever the facilities are available. So there are two approaches for the hernia repair. One is from the front open approach, and second is the laparoscopy. Parambilical hernia and the incision hernia you can also repair by open technique. Small hernia, small defect, primary repair. If the defect is large, answer is you place the mesh. Mesh me onlay mesh, inlay mesh, or sublay mesh. If there is a large incision hernia. Mesh neoplasty has stood the test of time. It has reduced the incidence of recurrence. Incision hernia is the complication of previous laparotomy wounds, especially more common in the gynecological sites or in the general surgeons who do not close the abdominal wall properly. Incisional hernia is a bad sign of a previous operation. One of the most important causes of incisional hernia, which is called ventral hernia, is poor surgical technique. You don't take a proper bite, facial bite on each side, at least 2.5 centimeter from the edge, and the distance between the two bites should be 1.5 centimeter, not more than that. And the filament you should use is suture material is monofilament, that is Poroline number 1 or 0. Second is previous operation wound infections. And third thing is the many other risk factors, multiple pregnancy, abdominal raised pressure because of the pelvic tumors. So because of these, you can have got the chances of incisional hernia. Poor surgical technique and the infection of the wound. There are two main principal factors which can lead to incisional hernia. Cancer is not the cause. Any patient you have done cancer patient के इसके बाद में इसका incisional hernia होगा, malnutrition की वजह से no. Poor surgical technique and wound infection. Especially in obese people, you do not able to appreciate the fascia of the abdominal wall. or the suture material is very weak, or the suture material cut through to the facial bite. So these are the factors which can lead to incision hernia. Partial dehiscence previously because of wound infections, and then later on it will be as a incision hernia. You have to repair it. That is all about the hernias: the inguinal hernia, femoral hernia, paraumbilical hernias, incision hernia. One hernia is also called obturator hernia, which occurs in the anterior part of the anterior pelvis. Obturator hernia usually present as acute intestinal obstruction because the knuckle of intestine is trapped into the obturator foramen. It presents as acute intestinal obstruction. Elderly ladies, multipara, sometimes 10% bilateral. The presentation is only by acute small bowel obstruction. And you get an X-ray, you find small bowel obstruction, you open it up, and you find the loop of the intestine is stuck down in the pelvis, and that is at the site of the obturator foramen. Sometimes it's bilateral, you have to look at for other side also. You need mesh, and sometimes you put a stitch. Usually the gut is gangrenous, you have to resect it and do the anastomosis if it belongs to small intestine. Large intestine, you have to do the colostomy. So this obturator hernia is very rare. It constitutes less than 1% of small bowel obstruction. Knuckle of the intestine is trapped into obturator foramen. From the peritoneal cavity, from the abdominal side, how do we recognize that this is the obturator hernia, this is a femoral hernia, or this is inguinal hernia? If the hernia is anterior to the inguinal ligament, it is inguinal hernia. If it is immediately posterior to the inguinal ligament, it is a femoral hernia. If it is lower down, much more there, it is called obturator hernia. Obturator hernia only present as acute small bowel obstruction. Sometimes the patient complains of the pain on the medial side of the thigh. When you do the internal rotation or the thigh, there is a pain along the distribution of obturator nerve on the medial side. But it is not a common sign. Sign is acute small bowel obstruction, diagnosed pain X-ray abdomen, and you find the gas shadow behind the pubic bone. But when you open it up, then you can treat with it. The majority of the patient, the gut is gangrenous, resect and do the anastomosis. Usually small bowel, it can entrapped into the obturator foramen. And in the posterior pelvis, there is the sciatic hernia which comes out to the greater sciatic notch, and that hernia can also really present as an obstruction, and this should be also operated to the abdominal side. And the other hernia is perineal hernia, which occurs in the perineum, and that is because of the pelvic extension, previous operation, or abdominal perineal dissections. Or rarely, some people they do in the United States perineal prostatectomy, in that you can get a what is called as the perineal hernia in the perineum. The treatment again to reduce the hernia, and you have to repair through the abdominal side. You open the tummy and reduce the hernia, and then you put a patch there, whatever situation exists. That is called as the perineal hernia. The other hernia is called parastomal hernia, that is around the stoma of colostomy or ileostomy, because the stoma hole gets stretched because of the intra-abdominal pressure and straining, and loops of intestine come along with it. Huge parastomal hernia should not be repaired, should not be operated if they are symptomless, and if they produce symptom or obstructions, then the answer is you can take up and repair it. But if it's not disturbing the function of the stoma, if there is no huge or prolapse which is very strangulated with bowels, otherwise even a big parastomal hernia should leave alone if there is no disturbance of the function of the stoma, or number two, if it is reducible, you can use the belt to reduce it. But anyhow, parastomal hernia can be repaired laparoscopically or by open technique, by placing the mesh. So you should remember the names of all these hernia: inguinal, direct, indirect, femoral, parabolical incisional hernia after laparotomies. Then you have got parastomal hernia around the colostomy, ileostomies, stomas, renal hernias, obturator hernia. You should know it, especially in elderly ladies, females, and then the shuttle that occur through the greater sciatic foramen. Remember two complications of the hernia. One, recurrence because of poor surgical technique, not a proper method adopted, and entirely depends upon the experience of the man. Cholecystectomy is easier operation as compared to a large recurring oral hernia to repair it because it requires every type of dissection, fine dissection, blunt dissection, sharp dissection, hemostasis. Anything which you do bad handling of the tissues will result in recurrence, infection, hematocele, groin hematoma. Rodney Menger used to say it, a hernia done by a good surgical craftsman, a good experienced surgeon who has his expertise doing this operation on kitchen table, the patient will go home without complication versus a surgeon who is not experienced, who is rough, don't care for the hemostasis and the tissues, planes. Even you operate at 7-story hospital at the top, the patient, and with the good sterilization, everything, the patient is bound to develop complication.